Good afternoon, everyone. My name is Carly Freiberg, a pediatric intensive care nurse. The use of physical and chemical restraints in mental health care has long been a contentious issue. Research by Cusack in 2018 shows that restraints can lead to physical injuries, psychological trauma, and in extreme cases, death. Beyond that, restraint use often damages the therapeutic alliance between patients and caregivers, potentially hindering long-term recovery. However, today I am excited to present a strategy that could revolutionize our approach to managing patients who are experiencing a mental health crisis with the implementation of a specialized de-escalation team. This team will be available 24/7 to respond to potential crisis situations. The team will consist of a psychiatric nurse practitioner or medical doctor, a mental health social worker, a peer support specialist, or an individual with lived experience of mental illness, and a security officer who is trained in mental health crisis intervention. This team will be specifically trained in advanced de-escalation techniques, including the verbal loop method, which involves a cycle of listening, validating, and responding to the patient. The rationale for this approach is evidence-based. Studies have shown that specialized response teams can significantly reduce the use of restraints. For instance, a study by Godfrey in 2014 found that implementing a behavioral emergency response team led to a 42% reduction in restraint use over 2 years. It has also been found that the inclusion of a peer support specialist has been shown to be particularly effective. A study by Chinman in 2015 demonstrated that peer support interventions led to increased engagement in care and improved relationships with providers. I have personally found it particularly helpful in de-escalation scenarios when you are able to relate in some way to what the patient might be experiencing. The implementation process will span across a 12-month period. Months 1 and 2 will include team selection and your initial training. Months 3 and 4 will be dedicated to protocol development and staff education. Months 5 and 6 is when we will roll out a pilot implementation. This will be used in one dedicated unit, which will allow for the collection of initial data and feedback from both staff and patients. And then months 7 through 12 is when full implementation will take place on all units, as well as ongoing training. The notification process will be similar to calling a code. You will give a brief overview of the situation. The team will arrive within 2 to 3 minutes. They will try to assess the situation. The security officer will be present. You will have your engagement period where the provider contacts the patient using the verbal loop technique, and the social worker and peer support specialist provide backup. The environment modification will help to reduce stimuli, dim your lights, low noise levels, clear the area of non-essential personnel. And then you'll have your therapeutic communication, which uses active listening and validation techniques and offer choices to the patient to give them a sense of control. And then you'll have your coping strategies where the peer support specialist suggests coping mechanisms like deep breathing, visualization, whatever works for the patient. And then you will have your resolution and follow-up, which develops a short-term safety plan with the patient and schedules a follow-up assessment. After each de-escalation initiation, there should be a debrief. This protocol will ensure that restraints are only used in the most critical situations, prioritizing dignity for the patient and safety. The evaluation plan will measure quantitative measures, which will include your frequency and duration of restraint use, number of crisis calls, and the patient length of stay. You'll have your qualitative assessments, which assesses staff surveys on perceived safety, patient satisfaction surveys, team debriefing reports. You will look at your clinical outcomes, which includes your rate of patient engagement in treatment and readmission rates, as well as your cost comparison between traditional methods and the new approach. By implementing this specialized de-escalation team, we have the opportunity to significantly improve patient care, reduce traumatic experiences, and create a safer environment for both patient and staff. This approach aligns with our commitment to trauma-informed, recovery-oriented care. Thank you for your attention, and I'm eager to hear your thoughts.